We're going to get halfway through already. What we need to, and then the last lectures are pretty short. So keep in mind that I'll probably be pulling more questions from longer lectures versus shorter ones. But just to kind of talk about where we left off here, we were talking about simulated melanoma being caused from certain medications, from iron, and also being certain types of foods and drinks that have red dyes. Beets has been notorious for that. You rule it out by just doing stool black. A lot of places are doing away from the bedside where you smear some fecal matter on there and you put on a little chemical and it tells you whether it's not as positive. A lot of labs have taken that over and you have to send it down. So always a fun time getting a stool sample from something. Not really. So just be aware of sometimes just because it seems like it's a lower GI bleed, we're having bright red blood, it can just be that that person has either significant amount of bleeding or that it can also be a very fast transit. So, more people are going to come in complaining of vomit in their, blood in their vomit versus in their stool. That's things are very subtle. Most people don't check the toilet after they go. So, older patient gets less likely they're going to do that. Just be aware that all these other symptoms that we're having, things added with that, hypotension, they're tachycardic, they're having chest pain, passing out, feeling weak, confusion. Some people, when they get older, they have very ambiguous types of complaints. They're not really sure what they're feeling. So kind of got to kitchen sink that. So why would we talk about GI bleeds and have any relation to angina? And please call it angina. It just sounds weird the other way. So that's called the type 2 STEMI, which is a supply and demand. I had this gentleman that I saw probably about every 3 months he would come into Madison. Always with a upper GI bleed, and always supply and demand. He's bleeding so bad, his hemoglobin hematocrit to transfusion. And that was to fix the problem. He didn't need a stent or anything for his non-ST elevation MI. We just had to fix the blood problem. So he was getting ischemia, angina in his heart because his blood was so low. It wasn't supplying enough oxygen. So that's a type 2 STEMI. So just be aware of that. You get these older folks that are bleeding really bad, they can have that type 2 STEMI. You need to get a troponin to get an idea that that's going on. So not because they're having necessarily chest pain, but it's more of a silent type of ischemia. Just be aware of that. How do we know with upper GI bleed what's the most reliable type of thing? Visual inspection of that vomitus is the most reliable way to tell. Hopefully they bring that in. A lot of folks will, especially older folks when they're concerned. They're going to bring it in. They threw up a little bit or coughed up a little bit into a napkin. We usually bring that in to the emergency department. If you have that, please hang on to that so you can show that inpatient team. Sometimes they're just, military medicine told you not revenue driven, so if they can send somebody back and then less work, you don't get any. There's no real incentive with that other than the goodness of the heart. So if you have a little bit of extra, show them, okay, this is concerning, especially if they're hypotensive and tachycardic. We need to go looking for that. So pay attention for other signs and symptoms, decreased pulse pressure, and then tachypnea. Just be aware that if somebody's bleeding inside of their belly, they can get paradoxical bradycardia. Paradoxical bradycardia. So, everybody know what that is? What do they call that? So somebody bleeds in their belly and suddenly they get bradycardic. You're like, that doesn't make any sense. So Cushing's, okay, that's Cushing's response. So just be aware of that. It doesn't always seem that somebody gets super tachycardic when you bleed out. Your other signs, make sure you're doing a good physical exam. We want to look at all these other things. Are they getting clammy? You're showing signs of diaphoresis. They're getting pallor. And then again, these other types of things, that's the four there, spider angiomas, pulmonary emphysema, jaundice, and gynecomastia are all synonymous with underlying liver disease. Now you got to be thinking, okay, they're not being honest with me, or maybe they are a recovering alcoholic, but they did their damage from years ago, so they are cirrhotics. Now we're concerned about those varices. Those varices don't just go away, we slow it down. And then again, inspecting the skin. So what's going to give us an idea of petechia purpura? How do we differentiate that from, say, a bruise? Okay, perfect. It has to do with the blenching, absolutely. So do a good exam on that. Sometimes that may be all that you see. Maybe all that you see. So good physical exams. Careful ENT. I told you about that lady that was just, essentially she was swallowing blood that was coming down from her posterior nasal cavity, posterior nasal lead. So just be aware of that. Careful ENT examination. You don't want to get your feelings hurt. If you think, call somebody a GI bleed and then they come down, be like, well, no, it's not coming from down the esophagus. So again, expose the abdomen, give you a good idea what's potentially going on, and then rectal exam to see if that maybe just be lower GI bleed versus upper GI bleed. But either way, that rectal is going to give you an idea, helps you quantify that, make sure that you rule out that this is not a rectal fistula, a hemorrhoid, a fissure, things of that nature, and make sure that you get a good idea of that. Because if you see anything, how are you going to describe anywhere in the rectum that you see anything that's going on? They're going to use a clock. They should do that. Should be an idea. And that gives you a good idea. Let that inpatient team know that you actually did that. They're not going to like it if that's something that you make sure you check on. So if we're really worried about that, they're super hypotense, they are super tachycardic, they syncopized, and we can get something called an I-stat. Is anybody familiar with that? That is a bedside blood test. And an I-stat is going to give you a bunch of different things, gives you some electrolytes, but the biggest thing I think we use I-stats for is an H&H right off the bat. Hemoglobin, hematocrit. Make a decision. It's like, do I need to type and screen and kind of let this run, or like I need to type and cross and I'm going to be ordering MAPS transfusion protocol quickly. So I told you that cross match, make sure that that all works. So type and screen if you might need a transfusion, type and cross if they're going to. Just be aware of that initial CBC may not reflect, slowly going down. Be aware of that. And then we always get that CMP. Why? Because we want that BUN. That BUN gives you an idea if that blood is being digested in the GI tract. It's going to absorb that into the blood system, cause that BUN to build up. And then obviously, we want to make sure a lot of these people are anticoagulated, so we need coag panels. We've gone away from having those off a lot because we've really gone away from warfarin. What did we always have to check with warfarin? Which lab? INR. So it just gives you an idea if is that something that we need to influence. So how do we treat warfarin overdose or too much warfarin? Vitamin K. Okay. So if a person's bleeding and they're a cirrhotic, they'll reach for vitamin K, they're not on warfarin. We'll get into what we're going to give them, but I get a lot of people, that's a phase 2 question, people pick vitamin K when you got a cirrhotic. So there's different medications, we'll talk about that in a little bit. Vitamin K is not going to help out. Again, EKG, you need to be worried about that. Type 2 in-STEMI, type 2 in-STEMI. Plus, that admitting team is going to want that EKG anyway, especially if they're older folks. So I would also consider lactate. Lactate's also a good idea in these type of folks, just to figure if there's any other underlying ischemia inside of the belly, be indicative of a mesenteric ischemia. So, and if that's elevated, then we know that they're in bad shape. Plus, it's also a great way to trend whether or not you're doing better. Now, what do we reach for as far as radiologic studies? Again, not a huge fan. No abdominal study is really going to help out with this, with the GI bleed. Now, chest radiograph maybe for considering we're having a ruptured esophagus and we want to see if there's free air somewhere. That's potentially to be considered. We do not mess with barium contrast because that goes in the abdomen and there's a significant rupture. That's in the strapsate. Endoscopy is usually where we're going to go with this, but in the event where we don't have that, we have tagged red cell scintigraphy. Okay, that's a nuclear medicine scan. We're going to put chemical in the body that's going to attach to the red blood cells to give us an idea where that bleed is. Much, much more common if they can't handle any type of studies. We can reach for this. We're going to call RADS. We see this a lot in pediatric populations. We talked about that Meckel's diverticulum. Meckel's scan is a red tagged red cell scintigraphy. So angiography can also help to determine what way do we go. Is this going to be a medical management or is this need a surgical management? But ideally, so we can, if somebody comes in, I came in and said she had vomited handfuls and handfuls of blood, which is a red flag. Put it in G2. Don't be scared to do that. I got back 0 blood, which was very reassuring, but cannot be 100% conclusive with that. So, NG placement, aspiration, give us an idea. Is this actually an upper GI leak? So that's going to go down, should not pass the ligament of Treitz, correct? So rest assured, usually if we're going to put an NG tube in, nurses are plus or minus on this. Patients, not so much. Anybody here had an NG tube? Ever? Not fun, isn't it? It's a good experience until you keep swallowing as they shove this tube down your nose. It's going to go ultimately into your stomach. You got to keep swallowing so it doesn't get wrapped up. Very interesting thing. Get an opportunity in phase 2. Have a nurse walk you through it. Get some time on it. Pretty interesting experience. Not for me, I haven't had it. So. All right, aspirate gives us a good idea if we have something going on. So that visual inspection is going to be the most reliable thing that we have. Most reliable thing. If we get to see that with our own eyes, or we have something going on, gives us an idea. We can kind of get an idea of, is this bright red blood? Is this kind of more of a maroon or coffee brown emesis? An idea what's going on. So this is going to be a gentle gastric lavage. When we do that, nurses can handle that. But we are going to use room temperature water. Please don't do that with cold water. The patient's not going to like that at all. So room temperature water. And again, no issues with this, whether they're cirrhotic or they're not. If you're at gastric varices, anything like that, it's no problem placing this in G2. A good idea of that. What else are NG tubes classically used for? So small bowel obstructions, right? Okay. A lot of times we're going to place that just because we need to give those people the bowel rest. And most of that's not going to be necessarily water, but sucking up the saliva that's continuously going down or nasal mucus. Okay, so risk stratification. So all these types of things are issues that can be higher risk for upper GI bleeds. Pretty self-explanatory on these. Especially the high-risk factors are the folks that have had it done before. And then obviously that transjugular intrahepatic portosystem shunt procedure, that's for your severe cirrhotics that have required surgery to go in because they have such severe ascites and portal hypertension that they have to go in and have that procedure. They basically put stents in all of the veins of the liver. So makes them super, super high risk. Why? Because they obviously did that much damage with alcohol already. Or did that much damage with alcohol, so just be aware of that. Now, people that very low risk, and when I say very low risk, you have to hit every single one of these criteria. You have to be under 60. You have to have no major comorbidities. You have to have no history of vomiting blood, no history of having blood come out from your backside. Your NG aspirate has to be negative. You have to be completely stable, normal vitals, no issues, and all your labs have to come back. You have to light up all those. If you hit anything in the high risk for me, then you're getting full line workup. Again, you have to everything in that left side, everything on the left side. So literature doesn't necessarily always support that, but make sure that they're less likely. They're going to have to hit every single one of those. Clear on that? Here's your treatment. So ABCs, as we do, we talk about emergency medicine. Obviously, we teach a little bit different when we're talking about trauma, but these aren't trauma patients, so I'm not going for that X. So, but we still want to hit this as quickly as possible. Make sure we get our safety net in place, and especially 2 large bore IVs. So that can be a little bit different for everybody what they consider large bore. I consider large bore either 14 or 16. Your normal patient is going to come in and probably get an 18, kiddos maybe a 20. Smaller kiddos 22 maybe, but you don't mess around. If you really need to give blood, you need to give them blood. Time and cross match, again, activate your massive transfusion protocol. That thing should run itself. But please review that when you get to your phase 2 site. What does that look like? Everybody has a little bit different protocol, and I know Dr. Casimir teaches you about the calcium gluconate every 4 units, but every place tweaks theirs. They have their hematology department and makes all those recommendations. You can be just a little bit different. Again, intubating when you're trying to suction out blood is very tenuous. It's already a difficult procedure. Now you got blood, you're trying to suction it out. So we want to make sure we're on top of that. So we activate that at massive transfusion protocol. A lot of places use an ABC score, and that's just if their pulse is above 120, systolic blood pressure below 90, and they have a positive FAST score. Any history of penetrating trauma, we need to know that. And obviously, when you go negative, there's some fluids in the meantime. Until that is going. So these people are volume down. They are not going to need as much sedative if you have to intubate. What do you usually intubate with? What medication? What's preferred? So you go ketamine. Ketamine's getting a lot more favoritism. Etomidate is very hemodynamically safe. Etomidate. Etomidate works great. Here's just a breakdown. So blood transfusion, we don't want to give them too much. If they're too high, we give them blood, that's not good. But we don't want to let them get too low, so the sweet spot is right between 7 and 9. We do not transfuse unless platelets are below 50,000. That's with any type of issue or platelet disorder. Again, another phase 2 question. I have platelets of 56,000. What do I do? Direct pressure if they're bleeding. You don't reach for platelets unless it's below 50,000. And omeprazole, that's our PPI. That's what we get on board for all GI bleeds. GI bleeds, we'll talk exactly about what that helps out with. And then known varices, not vitamin K, cirrhotic patient, known varices, octreotide. Octreotide, 25 micrograms per hour. And then we get antibiotics on board. Again, look at your protocol for this for upper GI bleeds, but either Cipro or ceftriaxone. Obviously, we're going to give that IV. This is just kind of full Monty what we do for these upper GI bleeds. Talk about that, using massive transfusion protocol. Be willing to pull that. There are certain things in the emergency department where we call something out and things start happening very quickly. Code STEMI, code stroke, massive transfusion protocol. Gets the ball going, gets people moving. So make sure that we're not giving too much fluids, hemodiluting too much, and then once we don't want to give blood if they're over that hemoglobin of 9 and cause heart. Right there, here's your thresholds. So usually it's below 7 for most patients, 9 in our older patients, the comorbidities. Restricted threshold is recommended pretty much across most treatment facilities. If they are an anticoagulant, we need to know that. Okay. We're at the INR, and you get vitamin K, if that's warfarin, and we have all these DOACs out there. Most of those do have reversal agents, but a lot of times we can get fresh frozen plasma in the interim. So, not going to test you on any INRs because warfarin's going out of popularity. But we don't want that. We're not going to wait to reverse that before we get an endoscopy, because that endoscopy can be diagnostic and therapeutic. Diagnostic and therapeutic. They have done tranexamic acid for upper GI bleeds. They have not found any benefit right now. Not found any benefit right now, but keep in mind, technology is about 2 years behind the power curve. Somebody could have some other evidence-based medicine, recent research that says TXA is effective. But right now, according to your standard for testing, TXA is not recommended. What is these guys right here? PPIs. That's if it's non-variceal bleeding. If it's variceal bleeding, we're going to reach for octreotide. So PPI is high dose. Why does that work? Because if the blood is too acidic, it won't clot. It will not clot. So this PPI is very life-saving, life-saving. So that gastric pH in blood remains high. The clot formation does not occur when the pH gets below 6. So we have to get it below 6. So PPIs do a wonderful thing. That is a whopping dose of PPI, by the way. That's most people are on about 20 a day. So we're going to give them 80 bolus. 80 bolus as they come in infusion. What does that do? Pay attention to this. So it reduces the need for surgery, always a good thing. Decreases the amount of time they're in the hospital, and then also reduces the signs of bleeding. Now for our cirrhotics or known gastric varices, because it's not always just cirrhotic, but we want to reach for octreotide. Anybody have any idea what else octreotide can treat? So it can help treat people that don't produce enough insulin in the interim. So these people that are seizing up because they have something secreting too much. So again, this inhibits secretion of gastric acid, so good for clot formation. Also reduces blood flow to the mucosa, and then has this crazy thing called splenic vasoconstriction. Not 100% proven, but essentially it works like an epinephrine, causing vasoconstrict. No benefit on mortality, but it's the best thing we got right now. Mostly these people, this is going to be a temporizing thing until we can get them scoped. And we can go in and bandage, cauterize them, whatever they need to do. And of course, antibiotics, especially in our cirrhotics. So you have to think of somebody who is a cirrhotic, has a severe history of alcoholism, is immunocompromised. You have to consider these people that, which is why antibiotics is so important. So important. Because all these types of things reduces infections, decreases mortality, and you get that going as soon as possible. Yes, ma'am.
Question on the antibiotics. So if we're giving them to cirrhosis patients, we also need to give antibiotics for compromised patients, like chemotherapy.
Absolutely, absolutely. So anytime somebody's bleeding inside of the gut, especially upper GI bleeds, I would go with antibiotics. I must give antibiotics almost every GI bleed. So, but once I've made that determination, they're coming in. If I haven't started yet and they're stable, so if somebody's unstable and they're febrile and have a white count, I mean, that's a hands down. I'm not even going to call anybody. I'm just going to pull the trigger. If I have somebody that's stable, like 90% of the patients I take care of, I'll do them a solid out of courtesy and say, hey, I was thinking about starting this. I mean, for this, you want me to start Cipro or ceftriaxone? I say ceftriaxone is probably more favorable. So not a lot of choices there. And then here's some other antibiotics that we can consider. This is if somebody's getting scoped. Now you've made the determination. It's actually during the day when you're seeing this patient, and gastro is in-house. They normally aren't. They go home every night. But they're in-house and they're willing to come and scope your patient, and you say, hey, do you want me to start some erythromycin or metoclopramide? So one's an antibiotic, one's an antiemetic, helps out with promotility, but either way, it enhances visualization with endoscope. Not like a colonoscopy where I don't think anybody in this room's right old enough to know what that's all about, but you got to prep for that for a whole day. Spend a lot of time in the toilet. This is a way to get things done quickly so that we can do scope from the outside. Not like getting scope from both sides where you gotta go, but I call that a rotisserie. It's pretty sweet. So large amounts of blood can be in there, but this erythromycin Reglan can be a game changer for you to get that going. What is the study of choice right here? As long as that patient's stable, can get them admitted, they can scope them in the morning. If it's serious, significant enough, then they need to be scoped as soon as possible. Again, diagnostic and therapeutic, 2 in 1 means that they're going to go in, they're going to confirm the diagnosis, and then they're going to do something hopefully to fix that. A whole bunch of different things. Usually within 24 hours. Emergent if they are unstable. Emergent if they are unstable. There are some temporizing things I'll show you here, but they're all just temporizing. This is just a list. I'm not going to ask you to spit any of this back out or test. I just need you to know there are lots of options. Just want you to be aware of these as far as litigation, sclerotherapy. They can do thermoregulation, sensory cauterize these things. There is potential, they may say, a lot of these specialists come down and you'll be the one that's running the sedation. So be prepared, you can be doing sedation for that scope. Sedation for that scope, usually propofol. Just be aware of the emergency department. If they're going to do a shoulder reduction, ankle reduction, any type of procedure, you better be ready to be by the bedside to run sedation because they don't do that on their own. Usually require an anesthesiologist in the OR, so just be prepared to do that. Always give, if somebody's getting scoped, please give them an antibiotic. Last thing that they're doing is gagging you for them during the scope. So there's some couple different things. Fentanyl and Versed have really gone out of favoritism. I really think that propofol is going to be money on that one. Propofol is going to be money on that one. So endoscopy. So consider those stable agents. We talked about that. Etomidate and ketamine being hemodynamically stable. That's where we want to go with that. If we are going to do that, I would stay away from propofol if your patient is unstable. And then just be reminded, I don't think anybody bageled for the IV lab. We'll see at the live tissue lab, but it does happen sometimes. So if that's unsightly for you and when they gag somebody and they go down their throat with an EGD, it's pretty intense. So that means you're passing out, so just be careful of that. But in temporizing type of thing, we're waiting, they're just bleeding, they're gushing like crazy, ruptured a huge varices. Short term, this is temporizing, this is not staying very long. We put a balloon in. High risk of complications because all that pressure is sitting down the esophagus. It's going to cut off blood flow, it's going to cause ischemia, all these types of things. Ulcerations can risk higher rupture, but again, this is kind of a last ditch effort. It's kind of like a thoracotomy. So we've lost pulses, but it's in the ED, and this is our last ditch effort, it's balloon tampon. So a lot of risk with that, You consider intubating before you do that, but here's how that looks. This is a Blakemore. You see it again through the nose, all the way down to the stomach, and inflate that balloon, and then pull it tight. But that is a lot of pressure in there, a lot of pressure. Gentle traction to pull that back because you don't want to have it too tight. It's causing more ischemia, more ulceration, more damage to that. Anytime you intubate somebody, and be real careful about it, trying more than twice, you're just causing too much damage to the tissues that are cause swelling. Same thing with this in concept. So, keep in mind, very horrible situation for the patient because you have difficulties, pretty much inability to swallow. And we have all these different types of surgical treatment, not responsive to any of the medications, the endoscopy's not working. Sometimes they can take them to the operating room. Now this is typically going to be a gastroenterologist that's going to do this, potentially a cardiothoracic surgeon, but they can do all these different types of things, shunt operations, non-shunt. And if it's non-variceal, and it's crazy, I mean, understanding embolization, that's cool, but doing a subtotal or total gastrectomy, yikes. Once that's gone, what do they replace that with? So, ultimately, your goal is to make sure you get that person to the operating room. Get them stabilized, get them put in that Blakemore, giving them massive transfusion protocol, maybe vasopressors, maybe fluids, doing what you can to keep them alive to get them to the OR, secure the OR, however that is. Significant, obviously ICU, get that person upstairs. If you're in the emergency department, I will typically call the ICU and say, hey, I got this massive upper GI bleed, but I've already talked to gastro and they want them up in the ICU where you guys have them stabilized and they're up there in a couple hours to get taken care of. As I said, load the boat, I think was the very first lecture that I gave you. You want to make sure that you can involve all those types of people who work together on that and let them know. That way there's no miscommunication where that resident told you in ICU, oh, I've already talked to gastro. And he really didn't talk to gastro, didn't know who he was talking to on the phone. But if that's going to be your patient, you still have control of them. It's your responsibility to sync everybody up. Questions on awesome upper GI bleeds? All right, some more time here looking at lower GI bleeds. Again, 3 more. Big surprise, distal to ligament trace. Distal to ligament trace. So that 36 out of 100,000 comes out to 0.00036%. Again, doesn't seem like a lot until you have a whopping 330 documented people. So just be aware that the upper GI bleeds are the most common source of GI bleeding when it's detected in the lower GI. So just because it's coming out of that the other end doesn't mean that it's not an upper GI bleed. Just high index of suspicion. It could be bleeding from above that. So most common cause. So what do we have for rectal bleeding? Rectal bleeding is hemorrhoids. Upper GI bleed, peptic ulcer disease, followed by varices if they're cirrhotic. Now we're talking about lower GI bleed. Lower GI bleed, you have to differentiate rectal from lower GI bleed. Because that will probably be on the pants. So lower GI bleed, diverticular disease. Then in order, colitis, edematous polyps, which is just early malignancies, and then malignancies. We get worried about that. What's the age for colonoscopy? Because that's going to be mostly a lot of what needs to be done with these. So 45 now. 45. Please encourage people to get that because we deal with a lot of colon cancers. Colon cancers are completely treatable if caught early enough. So here we go. We see most common, more of a female disease, and then increases with age. And then good thing is 8 to 9 out of 10 are going to resolve on their own without any intervention. Rest assured of that a little bit. So that's why I said lower GI bleeds, in my opinion, aren't as concerning as the upper GI bleeds, but either way. So make sure you got the right terms here. Metachesia is bright red or maroon colored rectal bleeding. Now a lot of times they say if it's bright red, they consider it's probably from a upper GI, but it's going to be a brisk upper GI if it is. So that can have some vomiting of blood along with hemodynamic instability. So we have about 10% of those for that upper GI bleeding. It's typically a brisk upper GI bleeding, which can be concerning. And then we have our melena. So usually means that's from an upper GI because it's had time to digest. So who here smelled melena? It's one of those smells that won't go away. Diabetic gangrenous foot is another one. But melena has a certain smell about that. Some people will say that C. diff also has a certain smell, and you get those experiences and it will be unforgettable. So, usually upper GI bleed, again, because it's had a chance to digest, we're typically going to see that BUN is probably going to be increasing as well. But it could be from a lower GI bleed for people that have maybe chronic constipation, irritable bowel disease, slow transit within their GI tract. Diverticulosis. We'll get a lot more into this in the next one. I think it's only like 24 slides of diverticulitis, but pretty common type of thing. But this is not associated with pain, even though it's going to be mostly the left lower quadrant. That's an erosion of the penetrating artery of the diverticulum. That is a weak area in the gastric mucosa. So most of the time this will resolve on its own, but just be aware that you can have right-sided diverticulosis and diverticulitis. If it's on the right side, much more concerning. That's going to be in the ascending colon, correct? Versus the descending colon. So, increased mortality in our older folks makes perfect sense. So we need to be careful and make sure that we're taking care of those folks. We need to have low threshold to transfuse them. Now my personal take on that, I have no problem starting a transfusion in the emergency department, but I'm not going to take that patients the whole time. There are schools that thought that emergency department should be a transfusion clinic. I completely disagree with that. I'm not going to sit there and monitor my patient, make sure they don't have a transfusion reaction for the time that I have them. Sure, absolutely. And then just be more concerned with those folks that are taking any anticoagulant. So for most emergency departments, people that come in, they're anticoagulated, the fast track refuses to see them. They would have to be seen by the EMED. That's just people's stigmata about that, but not everybody that's on anticoagulants is going to die. Just be aware of higher risk for GI bleeds, also with a lot of NSAID use. So these are just different flavors. Obviously, their diverticula as being number one. Vascular ectasias is also another common. So these are when all the vasculature in the mucosa gets fragile and easy to rupture and bleed. This includes your AVMs as well as your angiodysplasties. So just be aware, not only in the large bowel, it can also be in the small bowel. So these, unfortunately with AVMs, these vessels are going to have a higher pressure, therefore when they start to degenerate, it happens quicker. It happens a lot quicker. So be aware of valvular heart disease as that being a risk factor that's associated with vascular ectasias. They have valvular heart disease, higher risk for vascular ectasias. We have our mesenteric, ischemic colitis. So ischemic colitis, most common cause of intestinal ischemia, most common cause. Now this is transient in nature, and it comes and goes, but usually due to a combination of poor circulation as well as high bacterial content. How do they make that diagnosis? Usually by, so I'll use the term endoscopy, kind of as that could be either coming through the throat or through the rectum. Either one is endoscopy. Now, if we're doing it for a scope, it's an EGD, esophageal gastric duodenoscopy. And if we're doing it through the rectum, it's a colonoscopy. But either way, they are endoscopies. But this is diagnosed through endoscopy. Only about 1 in 5 will require surgical intervention. So there are all your risk factors there. I'm going to read those to you. I'm not going to say you're going to sit there and rattle off each one of those to your patients. Again, this is probably not a, you don't see very many questions on that, any on this. It's not very common. You should be aware of it. What I'm more worried about from a nurse medicine standpoint is this mesenteric ischemia. So we talk about things that are pain out of proportion. This is one of them. So as the person comes in with severe abdominal pain, this leads to bowel necrosis. And look at that, thrombosis or embolus from superior mesenteric artery. Now, why were these people thrombose or embolize? Because they have underlying issues with that. They're probably anticoagulated already. We run the risk of throwing clots when we have atrial fibrillation. It's probably one of the biggest issues with that. So when you have poor, low arterial flow, we run these risks. So again, pain out of proportion on exam. That's what POE means. Be aware of those things. That's a compartment syndrome, an necrotizing fasciitis, Fournier's gangrene, and a mesenteric ischemia. Those are the 4 that I would say we have pain out of proportion. So, in line, this can be a great mimicker with other abdominal issues. There's your index of suspicion right there. Raise your wrist. That person's over the age of 60. Now, don't get me wrong, there's some pretty spry 60-year-olds out there, but this is just where things are. And now that I say AFib, CHF, they've had a history of an MI, so they've clotted up before, and can probably clot again. Pain after eating, which makes you think more gallbladder or something. Pancreatitis, something's crushing enzymes, but not. I explain weight loss. So CT, angiography. CT angiography, if you're worried about that. And what are you probably going to get as a lab? You're probably going to get a lactate. Lactate's going to give you an idea that there's underlying ischemia, which can be related to either one of those. There's a little bit more of a suspicion. So angiography. This is a bad thing. If they get mesenteric ischemia, it's just not, it's really not a good outcome. I'm sorry, so 50%. So 1 in 2. That's crap. So you have an arch nemesis, this is what you want to have. We talk about Meckel's diverticulum, talk about this a little bit more. That's when we talk about a tag red cell scintigraphy, nuclear medicine scan, also known as a Meckel scan. So this is from embryonic tissue. This is a kiddo disease, usually around the age of 2. So found in the terminal ileum, right side, right lower quadrant. So there's going to be ectopic gastric tissue that essentially secretes enzymes. These enzymes end up eating through the mucosal wall, causing bleeding. So usually painless, but rectal bleeding, underpopulation. Parents come in because they found blood in their baby's diaper up to the age of 2. But the kiddo looks great. What the heck? Just be aware, Meckel's scan, yes, it does need research requests. Some other wonky stuff just to be aware of. So your aperture is wide, you cast your nets. So we have infectious from bacteria, we have radiation related from people with chemo, people can have rectal ulcers, there can be trauma. We go in the realm of inflammatory bowel disease, which usually comes in 2 flavors. Ulcerative colitis and Crohn's. Most of those people already know that they have it. But if it's severe enough, they need to come in, get treated. We talk about polyps and all that stuff. After a polypectomy, that's usually from a colonoscopy. If they remove the polyp, there's a chance that that can bleed worse. And then left ventricular assisted devices, you're not going to see a lot of these LVADs. Maybe in the homeless population, because that's the only thing that are going to be done to them because they have no health insurance. Not very often that you're going to see that. So, what do I have there? I want to make sure that you differentiate rectal bleeding from lower GI bleeding. Hemorrhoids is lower GI bleeding. You always have to check that. Make sure you get a good rectal exam. Here is a complete list from the book. Now, I'm not going to say list off as many of this as you know that I'm going to test that type of thing. Just be aware that there are a lot of different things. If it's not on your differential, you're not going to diagnose it. Not on your differential, you're not going to diagnose it. So, rely heavily on your history or physical exam, provided you have a stable patient that you can ask all these questions and examine them. But if you have to, you need to simultaneously resuscitate these folks. If I'm kind of waiting and figuring stuff out, I have no problem hanging a liter of fluids and having it go in just so I'm doing something. There's all your high risk morbidity rates. Pretty simple for most of those types of things. Pretty simple. But just be aware of if they do have a non-tender abdomen, they're bleeding. It's very concerning if they're an old person. So that's predictive of severe bleeding. And then obviously their history of asthma continues. Predictive diverticular hemorrhage. Most patients will be coming to the hospital. Most of the time they come in because they say they found something. They went to the bathroom and they were flushing the toilet and it was full of blood. For whatever reason, it's never just a little bit. They always say it's full of blood. Always. I've never had anybody say, not just a little bit. Come in. Or I was wiping out a little bit of the toilet paper. Like that's probably a hemorrhage. But it's severe. We need to get after it. Make sure they're checking that. Asking about all these types of things, especially history of GI bleeds. Very helpful if they've had GI bleeds, just to know it's likely what it is again. But I want to make sure, is there any pain associated with that trauma? Have you put anything in your body? I'd be really surprised if there's underlying psychosis. People eat weird things. Like a guy that ate 50 toothbrushes. I don't know why, but he's in pretty severe abdominal pain and rectal bleeding. Underlying people with psychosis, you're not going to necessarily see a lot of that. With military folks, definitely a lot more downtown. I got to train downtown Seattle and tell you the weird stuff that you've seen and where people manage to shove things in their bodies. So weight loss, again, that should be a red flag for your weight loss. Give you an idea that there's an underlying malignancy on anything. And then bowel habits, changing bowel habits. What do I say? Once you had normal Stools, now you have essentially pencil-sized stools coming out. Very concerning that there's a malignancy that's in there. And then again, we talked about that aortic graft. If you have somebody with an aortic graft, and the question says, is it an aortic enteric fistula? The answer is yes. The answer is yes. Talked about all these types of things as far as antiplatelets, anticoagulants, NSAIDs, and then I told you about that simulated analgesia. Talked about bismuth, salicylate. Let's talk about certain foods. Beets is the big one there, and then iron and bismuth. What do you need to be worried about? We walk in. I always have vitals before I walk in. I have an idea. Do I need to get in there quicker or not? So hypertension, tachycardia lets me know. Maybe there's some hypovolemic shock starting. And then that decreased pulse pressure. What is decreased pulse pressure? Systolic and diastolic. Very close. Should be at least usually 20 to 30 apart. If that's getting closer than that, we need to be really concerned that something's going on. So just be aware of your older folks. Some of that can be masked. I told you have an old guy comes in, he's like 120 blood pressure. But see, like he lives at like 200. He's great that day, but anyway, some people with their beta blockers can kind of mix this up and take a big enough beta blocker, or sometimes all people forget and they take their medication several days. So make sure you're looking at their symptoms, their skin symptoms, because regardless of what the vitals say, you should be able to look at the physical exam and have a better idea of what's going on here. And then again, looking for that liver disease. Do I need to reach for some coagulation medication? Do I need to reach for octreotide? Definitely, if I'm seeing signs of significant alcoholism that's been going on, I think this person is immunocompromised. I'm going to reach for the antibiotic earlier than later. Reach for the antibiotic earlier than later. So, abdominal exam, make sure you're doing a good job on that. And you want to be able to tell them on the phone, if you're saying I have a lower GI bleed, but my abdominal exam is completely normal, no tenderness or whatever, make sure that you're getting that out. So, inflammatory bowel disease, the lower GI bleed, typically going to have a lot of abdominal pain with that. And then, of course, your rectal exam, make sure that there's not some iatrogenic reason that caused that. Make sure you're not seeing any concerning signs of masses, dramas. And of course, looking to make sure that it's not actually just rectal bleeding and not lower GI bleeding. And we'll stop there. So, and then LFTs. Again, I add the BNP, I add the LFTs. That's just the way I've been doing it for years. Up to you how you want to do that. Up to you how you want to do that. And just be aware that initial hemoglobin hematocrit that comes back may not have caught up and may not be super reflective of how much blood loss. So again, if we see that BUN is like through the roof and we have a baseline, we look back like a year ago, it was normal, and now it's high today. Likely upper GI bleed has had a lot more time to digest all that gastric breakdown of the blood would happen in the stomach, esophagus down the stomach. So we're going to see that elevated. Again, cannot reiterate this enough. Some people will miss it. EKG, concerned about coronary artery disease, silent ischemia with that type 2 instant. It's silent. They're not complaining of chest pain. They're more worried about their GI bleed, but their heart's taking a hit. Again, no stents. We're going to do a PCI. We just need to fix the problem. We need to put more blood in the body. No abdominal radiographs unless you're concerned for these types of things. So a perforation, we're going to look for free air, an obstruction, and you're looking for a small bowel with dilated loose bowel, and then foreign bodies if we're worried about those type of people with their abdominal pain. It is out there if you're anywhere near the border, Mexico. So body packers, we use x-rays for that. Be surprised what comes in with the emergency department sometimes. Be surprised. So if you think you have some pulmonary findings, yes, it's warranted to go for the chest x-ray, sure. And then we do not touch barium contrast. Do not touch barium contrast. Procedure choice, angiography. Angiography is being number one choice. Angiography. So pretty good. We check a relatively brisk rate of 0.5 mLs per milliliter. So also allows therapeutic options as far as embolizations and infusion of vasoconstrictive substances. So there's other things, scintigraphy, there's endoscopy. There we go, our scintigraphy, that's what I talked about, mostly kiddos. It's even more effective than CT angiography, but it doesn't allow you the therapeutic conditions. So basically it's going to give us an idea, do we need to push for angiography or do we need to go ahead and surgerize this? Again, this is going to be in our kiddos for the most part. And I already told you that medical spec. Talk a little bit more about that diverticulitis. This is the awesome one. This is like the gold standard, but I doubt your treatment facility has this multi-detector CT angiography. Outstanding, very expensive. Not going to find that in most military treatment facilities, and I don't think they even have it. Go ahead, sir.
I know the CT angiogram is great, but is the scintigraphy also pretty quick, or is that?
It's pretty quick, yeah. Not as fast as the angiography. We want to avoid the CT. It's honestly, scintigraphy is going to be for the kiddos or somebody who can't tolerate CT with contrast. So there are people out there that are completely allergic, going to anaphylaxis from it. There are people that are out there that their kidney function is so in the toilet that they would never get approved to get a CT with contrast. That's where the people that reach for the scintigraphy. So can't tolerate contrast and kiddos. And then probably if you had a pregnant lady that was bleeding somewhere as well, scintigraphy would be the way to go for that. Pretty simple. We're going to resuscitate anytime we're worried about blood loss. We should start them on oxygen and put them on telemetry, cardiac monitoring. And then again, large bore IV, same with an upper GI bleed. If there is a correctable coagulopathy, we need to do that. And then there's your transfusion criteria. We already talked about it does not change from upper GI bleed to lower GI bleed. So if we are going to give crystalloids, what's our initial amount? Usually 20 mLs per kilogram is about what we should give them. Hopefully they are fluid responsive. If they are not, they are refractive. We need to be reaching for electrolyte pretty freaking fast. Okay, blood transfusion right there. Failure to improve, so it becomes refractive to what you've done with crystalloids. And then threshold for blood transfusion in the elderly for sure. So, NG tube, if it's significant, because we want to make sure it's not an upper GI bleed. And then, like I said, about 10 to 14% of the time is from an upper GI. Early consultation, reach out for that. If you do your rectal exam and it's like severe bleeding, I'm going to get that eye stat, and I'm probably going to go ahead and make a phone call to GI potentially, or to a surgery, whoever is going to take care of this massive lower GI bleed. Let them know, hey, here's what's going on. Gastroenterologist, especially if it's uncontrolled, that gastro tube will be right down there to get on top of it. Not likely they're going to scope them in the emergency department, but they could. They could eventually. Flexible, this is more, they got time to figure things out. So flexible sigmoidoscopy. So distal types of issues, that's going to go back most of the time. This is usually used to find internal rectal hemorrhoids versus the colonoscopy. If they can't really figure out and that they've done all the studies, say they do tag red cell scintigraphy, they do angiography, they can't figure out what's going on, well, they're probably going to get a scope on that person before they leave to see what's going on. And that scope will not only be diagnostic and therapeutic, maybe it's a polyp, they're going to go in there and do all these different things, banding, clipping, injecting, or cauterizing. So, and then if they can't figure out what's going on then they're going to go ahead and do an EGD. Let's go from the top if they didn't figure out what's going on. So maybe it's an upper GI bleed. Again, it's a guessing game. It's good if you're having that much trouble finding it, because it probably means it's not that massive of a bleed. Probably not that massive of a bleed. And here's your disposition. Almost everybody that comes in with a GI bleed, especially lower GI bleed, I'm just gonna go full Monty, they're going to get omeprazole for lower GI bleed. I'm probably gonna start them on some Rofcepin, and I'm going, obviously I'm gonna do my exam, check all the labs, see if there's any other interventions I need to do, if they need to come to the hospital for that evaluation. Any point that they're unstable or they're having significant bleeding, they need to go to the ICU. And then we have all these other types of things that make things a little bit more concerning. Obviously, if they're hemodynamically unstable, they continue to have rectal bleeding while they're in your emergency department. Again, non-tender abdomen is not a good prognosis. Usually means there's massive bleeding going on. And then obviously the other issues here. I told you there's risk stratification scores. They don't haven't all been completely validated, but I told you they would have to hit that entire left column where they completely have an unremarkable exam under the age of 60, no history of symptoms like that. Pretty easy. You're going to get a lot of folks that come in. It usually they wiped, and that's when they see the bleeding, and that's going to be more hemorrhoid fissure related. This can be very painful. So I'll leave that more for your surgery rotation. This is not more a big emergency medicine type of thing. It's more surgery rotation as far as which one of those do you cut into, and which of those do you consider banding and whatnot. So, questions on lower GI bleed?